Hello everyone. So in this session we are going to discuss the mammary gland. So let's start with the topic. So actually it's an important topic we have to know. So it's surgically also very important. Many questions will be asked from the surgery part. But for understanding the surgical part, you have to know the anatomy of breast and the mammary gland. So I want you to explain this. The breast consists of mammary gland and associated connective tissues. The mammary gland, if I talk about what is exactly mammary gland, it's a modified sweat gland. Say modified sweat gland, and actually the location of mammary gland is in the superficial fascia of the pectoral region. So when you go for the dissections of the pectoral region, what you will find, before reaching exactly to the muscles and in the superficial fascia itself, you get the mammary gland. Now here we can see, I just want to enlarge this image so that you can see the mammary gland. In the center there is the nipple and the surrounding area. So this is nipple, this is the areola. So exactly the nipple is located, nipple and areola are the structures of the mammary gland which is located in the skin area. The location of nipple is in the fourth intercostal space. So exactly the extent, agar hame ye bhi janna hai, what is the extent overall? It is a hemicircular bulge in the anterior aspect of the chest, which is exactly extending vertically from the second rib to that of the sixth rib and from the lateral aspect of sternum to the mid-axillary line. So that is an important extent. So I just want you to show this. Exactly this is exactly showing this is the sixth rib, this is the second rib. So this is the vertical extent, and in the horizontal extent it is extending till the level of mid-axillary line starting from the lateral border of the sternum. Actually in the superolateral quadrant you can see there is an extension of mammary gland which is called as axillary tail of Sphinx, which is passing through a gap and traversing into the deep fascia. That gap is called as foramen of Langer. So here you can see the foramen of Langer also. So extent is from vertically, the breast mammary gland is extending from second to sixth rib level, and horizontally, if I talk about the extent, horizontally it is extending from lateral aspect of sternum to mid-axillary line, Okay, this is the extent of and location of the breast in the superficial fascia. Other than that, it is also important to know, other than that, I told you from the superior quadrant, from the supralateral quadrant. So I just want to rub this and I just want everybody to focus on this image. So as you can see here, this is the breast which is circular, as you can see, hemicircular bulge in the anterior aspect of the chest. From the supralateral quadrant, if I divide the whole of the breast into four quadrants, supralateral, supromedially, infromedial and infrolateral. So from supralateral quadrant of the breast, there is an extension which is called as axillary tail of Sphinx. Why it is very important? Because it's a normal thing. So you should not confuse with any kind of lymph node enlargement or any palpable mass of the breast. You should have this clear concept of anatomy that it is an extension from the supralateral quadrant of breast traversing through the space that is called as foramen of Langer. Now let's talk about the relations of the breast. So when we see the breast, which is a modified sweat gland, it is actually on the deeper aspect, it is having the relations with the pectoral fascia, which is covering the anterior aspect of pectoralis major muscle. Now, in between this pectoral fascia and that of the breast, we have got a space. This space is called as retromammary space. Which space is this? This space is called as retromammary space. So, what is the importance of this retromammary space? This is allowing the breast to be movable on the anterior aspect of the chest. Now, on the deeper aspect, we will have the more of the muscles related. So, we will have the part of serratus anterior, external oblique, pectoral group of muscle related in this area. So, relations of the breast, posterior to breast lies pectoral fascia, and in between pectoral fascia and mammary gland or breast, we have got a space. That space is called retromammary space. Retromammary space. The importance of this retromammary space is it is allowing the space on which is consists of loose connective tissue over which the breast can be moved. Other than more posteriorly, More posteriorly, we have got muscles like pectoralis major muscle. We have got serratus anterior muscle and the fibers of also external oblique muscle. So actually these are few muscles which is forming a bed on which the breast is lying. Other than that, let's talk about the structure of the breast. So basically the breast is composed of skin, certain structures which is lying in the skin, overlying skin, that is the nipple and areola. Nipple is located in the fourth intercostal space in the center of the breast, and the darker area around the nipple is the areola. Why it is dark? Because it is dark and it is having some glands also. So that is for the oily secretion, that is contains sebaceous gland, and in case of pregnancy that glands increases in size and that is called as Montgomery tubercles. Now, other than that, if I talk about the connective tissue framework of the breast, it is made of fibrous septas, which is called as suspensory ligament of breast. And if I talk about the parenchyma of the breast, it is consists of the lobes, lobules, the lactiferous ducts. Okay. Now, so here you can see in this diagram, there is ligament of Cooper's, which is the fibrous septas, which is connecting the dermis skin layer with that of the lobes of the breast, and to the overlining it merges with the pectoral fascia. This is giving structural support to the breast and it is preventing the breast from sagging down. The connective tissue framework is giving support to the parenchyma of the breast. The parenchyma of the breast is made of lactiferous lobes, lobes of the breast, lactiferous sinus and the lactiferous duct, which is important for the milk secretion, and the skin is there which is containing the areola and the nipple. So that connective tissue framework, which is in the form of fibrous septa, is called as ligament of Cooper. So breast is having skin, breast is having connective tissue framework, breast is having parenchyma. Skin is containing nipple, areola. Connective tissue framework is in the form of fibrous septas, and this fibrous septas is forming suspensory ligament of Cooper. This is forming suspensory ligament of Cooper. And parenchyma is important for the milk secretion. Now here, if you will see the structure of, so if I talk about the if I talk about the connective tissue framework, it is primarily consists of the fibrous septas, which is connecting the dermis and the skin layer with the underlying pectoral fascia and that of the lactiferous duct, and it is giving support to the breast. Other than that, parenchyma is primarily composed of lobes and lobules, which is containing, so we have got 15 to 20 lobes in the breast, which is arranged like a radially arranged. All of these are converging towards the nipple and areola. The areolar part is, nipple part is lying at the level of fourth intercostal space. The areolar part is the surrounding area, and if I talk about this areola part which is surrounding the nipple, it is darker more in the case of pregnant women. It contains some sebaceous gland. And what is the function of these sebaceous gland? Oily secretion is there. The function is oily secretion, which is important for giving lubrication. This sebaceous gland is more enlarged and more of secretion is there, and it is enlarged in case of pregnancy, lactation, and that condition is called as, that elevation and enlargement is called as Montgomery tubercles. Now we can see the lobes. We can see the lobes, and the lobes there are 15 to 20 lobes in the breast, which is consisting of lobules. Inside we can see the acinus are there. So many acinus are there in the lobules and the duct. And at the all these ducts, lactiferous duct is converging around towards the nipple, and at converging point of the nipple, just close to it, there is lactiferous sinus, which is acting as a milk tank. When stimulated, it will secrete the milk. So that means there is 15 to 20 lobes in breast, which will further divide into lobules, and inside the lobules there is lactiferous duct. And lactiferous duct, when all will converge near the nipple, it will form lactiferous sinus, which is called as milk tank. What is it called? It is called as milk tank. Now, I would like to show you another image. Let me just enlarge. What you can see, these are the suspensory ligaments. So I just, okay. So you can see in between there are so many of lactiferous sinuses. So in between there are too many lactiferous, in between there is fibrous septas, and these all septas are supporting the suspensory ligament, supporting the breast parenchyma. Now, so if I talk about the breast, it is made of fat also, and here lobes of the mammary gland, which is containing lactiferous duct, SNS are there, alveoli, and all these SNS are converging towards the nipple, and just close to it you can see these is the lactiferous sinuses, which is acting as a milk tank. Now, so that is important for us to know. Other than that, I would also like to talk about the other. So these are the basic features which is seen. That means one of the important support framework which is given to support framework is a connective tissue framework which is supporting the breast from sagging down, and it is more in the puberty, and when the lady get older, that connective tissue framework or the suspensory ligament of Cooper is not so strong and the fibroceptor, so the breast will sag down. So this is forming suspensory ligament of Cooper. Now, other than that, let me just show you another image where we can have a detail of the arterial supply. If I talk about the arterial supply of breast, it is from the sources of branches from, so we have got a lateral branch of posterior intercostal artery, we have got the superior thoracic artery, the acromiothoracic artery, lateral thoracic artery. So these three are the branches of axillary artery. So the source of blood supply, arterial supply, is from axillary artery via lateral thoracic artery, thoracoacromial artery, superior thoracic artery. Other sources, perforating branches of internal thoracic artery, which is given at the level of second, third and fourth intercostal state, and branches of posterior intercostal artery. So write down arterial supply of breast. Arterial supply of breast is via following branches. The important branches which is giving arterial supply is axillary artery branches. So if I talk about axillary artery branches, which branches of axillary artery? We have got three branches. We have got superior thoracic artery, which is also called as supreme thoracic artery. The other is lateral thoracic artery, and the other is acromiothoracic artery. So this is the first source. The other sources are the branches of internal thoracic artery and posterior intercostal arteries. So other sources is posterior intercostal arteries, lateral branch, and branches of internal thoracic artery. So if I talk about the branches of internal thoracic artery, basically in the second, third and fourth intercostal space, we have got the perforating branches. Now, other than that, I would also like to tell that the vein, if I talk about the venous drainage of breast, the venous drainage of breast is corresponding to the arterial supply. It's corresponding to the arterial supply. Now, let's talk about the lymphatic drainage. Before that, I would also like to write just one line about the nerve supply. Actually, stimulation of milk secretion is more of hormonal, not of neuronal, but it is more of hormonal. The other than that, nerve supply is via second to sixth intercostal nerves, which is via anterior and lateral cutaneous nerve, Now, lymphatic drainage of breast. So, अगर हम source की बात करते हैं, lymphatic drainage of breast has getting the lymphatic drainage via axillary group of lymph nodes, via internal mammary group of lymph nodes. We have posterior intercostal lymph nodes. So, I would like firstly to show you the images. So, firstly, let's see the images so that you can understand this. So, we have got axillary group of lymphatics. Basically, we have got anterior, posterior, and we have got also the deltopectoral, and the other groups all will go to the supraclavicular lymph. So basically, these are the primarily lymph nodes which is involved in lymphatic drainage. Other than that, we have got posterior intercostal lymph nodes, internal mammary lymph nodes. So these are basically very important for the lymphatic. These are the source of lymphatic drainage of the breast. Other than that, I would also like to tell that basically the skin of the breast and except that of the nipple and areola is all draining into superficial lymphatic group, and the other are draining to deep lymphatic drainage of the breast. So that is important for us to understand. So these all will form actually deep lymphatics will form subareolar plexus of Sappe, and this will drain into anterior axillary lymph nodes. So that means lymphatic drainage of breast can be categorized as superficial lymphatics and deep lymphatics. So superficial lymphatics is draining whole of the skin of the breast except nipple and areola, and deep lymphatics is draining the parenchyma of the breast and the nipple and areola region. So that together the deeper lymphatic group will form subareolar plexus of Sappe and will drain into anterior axillary group of lymph nodes. So here I just want to show this image so that you can understand. Actually these images are very so exactly the major source of lymphatics की बात करेंगे तो we have got axillary lymph node in the source. We have got intercostal, posterior intercostal lymph node in the source. We have got internal mammary lymph nodes. We have got deltopectoral, deltopectoral group of lymph nodes. We have also called subdiaphragmatic lymph nodes. So this is exactly the source of lymphatic drainage. Now I would like to show you an image for it so that you can understand. So when I am enlarging this image, you can understand the basically how this happens. So exactly you can see for understanding this, I just want to enlarge this. For understanding properly, अगर हम इसको understand करना चाहेंगे, तो we have divided this whole the whole of the breast into 4 quadrants. So you can basically see the upper medial. If I talk about the upper medial quadrant, it is draining into internal mammary lymph node of the ipsilateral side and also of contralateral side. The lower medial group is also draining lymphatics to the internal mammary group of lymph node, and also a few of the lower medial quadrant of the breast. It will form subperitoneal lymphatic plexus and can also communicate and get deposited and the ovary, forming Krukenbeck secondary tumors. So that is subperitoneal, subdiaphragmatic lymph nodes. If I talk about lateral quadrant, few lymphatics will drain into posterior intercostal, other will drain into, as you can see, if I am talking about others will drain into, as you can see here, into axillary group of lymph nodes actually, and also upper lateral will basically drain into anterior. So it's basically draining into the lower lateral is draining into posterior group of axillary lymph node. The upper, superior upper or upper lateral will drain into anterior group of axillary lymph node. They will form communication with the central lateral and ultimately will reach the deltopectoral and apical group of axillary lymph node. So exactly अगर आप ये image देखोगे, you can understand the whole lymphatic drainage of different quadrants of the breast. So basically major lymphatics is draining into, if I talk about the major lymphatic drainage, it is approximately 70 to 75% are draining into an axillary group of lymph nodes, 20% is draining into internal mammary, and 5% is draining into posterior intercostal group of lymph nodes. So 20% lymphatics drains into internal mammary, 5% to the posterior intercostal, and major axillary lymph nodes drainage is 70 to 75%. So done with this. Now I would like to just go through few important things which is very important, clinical anatomy. So I would also like to solve the clinical anatomy part of the breast, because डायरेक्टली अगर प्रीवियस ईयर के क्वेश्चंस देखेंगे तो ब्रेस्ट से डायरेक्टली एमसीक्यूज बहुत नहीं आए हैं, बट इफ आई टॉक अबाउट द क्वेश्चंस बीइंग सॉल्व फॉर द क्लिनिकल एस्पेक्ट्स एंड सर्जिकल एस्पेक्ट, द क्वेश्चन हैज बीन आस्क्ड. सो लेट्स टॉक अबाउट द क्लिनिकल एनाटॉमी. सो व्हाट इज द इंपॉर्टेंट ऑफ एक्सिलरी टेल ऑफ ब्रेस्ट? व्हेन आई एम टॉकिंग अबाउट एक्सिलरी टेल ऑफ ब्रेस्ट, इट्स क्लिनिकल इंपॉर्टेंस इज दैट व्हेन वी वांट टू इवैल्यूएट द पैथोलॉजी ऑफ द ब्रेस्ट, the upper lateral region of breast, if you will see, there is a projection from upper lateral quadrant of the breast which is called as axillary tail of Sphinx, which will pass through a foramen of Langer. So the axillary process is called axillary tail, which will perforate the deep fascia and will extend into the axilla. So that perforation of the deep fascia is in the foramen of Langer. So the other important clinical aspect is breast cancer. So it is very important to know the axillary group or the other group of lymphatics which has been involved for staging the breast cancer. So breast cancer is one of the important malignancy and a common malignancy seen in the case of women's. It develops in the cells of SNI. It also develops in lobules and lactiferous duct. Tumor growth spread is important to know the origin of cancers and spread. If I talk about the spread of infection, the spread of metastatic cells and the cancer cells happen through the lymphatics and the veins or by a direct invasion also. Now, staging of tumor of the breast can be done by the size of primary tumor, the exact site of primary tumor, number and site of lymph nodes which is involved and spread has happened, and the organs to which the tumor has spread. So these are 4 points for staging the breast cancer, because that is why it is very important that the staging of breast cancer should be done for a proper therapy given to the patient, whether it will be hormonal, whether it will be surgical, whether it will be combination of surgical, radiation therapy or the chemotherapy. Now, subcutaneous, I would also like to talk about other clinical aspect related. Subcutaneous, if there is a case of lymphatic obstruction, if there is a case of lymphatic obstruction and tumor growth, it will pull the connective tissue and ligaments of the breast, and this will result in the appearance of orange peel texture that is called as pseudo-orange appearance, or the pitting of the breast will be seen. So this is the reason why. So the lymphatic obstruction, pulling the connective tissue ligament, is the reason for the appearance of orange peel texture, that is the orange peel appearance, pseudo-orange appearance of the breast. The subcutaneous spread can cause a rare manifestation of breast cancer. Because of this, the whole of the breast will appear wood, hardy texture of the skin cancers. Now, other than that, I would also like to talk about the surgical therapy of the breast, in which the whole of the breast is removed. That is called radical mastectomy. So surgical removal of the breast involves excision of breast tissue to the pectoralis major muscle and fascia. Within the breast tissue, the medial axillary wall has been approached. So exactly what happens when we know that medial axillary wall, we have got an important nerve, that is long thoracic nerve, giving innervation to serratus anterior muscle can be involved. And we know that if long thoracic nerve is injured, what will happen? It will lead to paralysis of serratus anterior muscle. And we know that serratus anterior muscle has got a function of protraction of the scapula. So when you tell the patient to pull against the wall, the medial boundary or medial wall of the scapula will be exposed on outward aspect, and that condition is called as the condition of winged scapula. It is also possible that nerve to latissimus dorsi can be extended and can be involved in this case. Basically, the most common nerve to be injured is long thoracic nerve. Other than that, nerve to latissimus dorsi can be involved in this case, that is seen in this case, and it can affect latissimus dorsi muscle. And we know that action of latissimus dorsi muscle is extension, medial rotation, and adduction of the arm. I would like to talk about a secondary tumor involved by the breast cancer source, that is called as Krukenberg tumor. So this is an image which is shown for the Krukenberg tumor. So Krukenberg tumor is the deposit which is seen in the ovaries by the spread of carcinoma of the breast. So I would like to discuss how this spread of infection happens. So lymph from the inframedial part will communicate with the rectus sheath, and thereafter it will pierce the linea alba, which is the merging of the muscles, flat muscles of the abdomen in the midline. And from here, it will form subperitoneal plexus. So what it is forming? It is forming subperitoneal plexus, and then it will drain into subdiaphragmatic lymph node. Thereafter, it will pass through the falciform ligament of the liver and will involve the hepatic lymph nodes and will cause a condition which is called as obstructive jaundice. It will lead to the condition of obstructive jaundice. I want everybody, this route of infection is very important, taken from Gray's Anatomy. Please understand this route of infection, how the metastatic cells spread to form the secondary tumors. Tumor cells will drop from subperitoneal plexus into the general cavity and will enter the ovary, and this will happen through the ostia of the left ovulating Graafian cells follicles and will form secondary deposit on the ovary and will lead to a condition which is called as Krukenberg's tumor. So all of you, please go through this mode of infection and mode of involvement of secondary deposit involved in the ovary, and the primary cause is carcinoma of the breast. Now I would like to solve few MCQs along with you. Let me read it for you. A 34-year-old female has difficulty in abducting her right arm past horizontal position and abnormal prominence of the right inferior scapular angle is also observed. Which of the following is most likely the cause of patient condition? Thyroidectomy, anterior dislocation of shoulder joint, violent stretch between the head and the shoulder, clavicular fracture, or mastectomy. So actually the key points which you have to pay attention here is the female is having difficulty in abducting. The female is having difficulty in abducting her right arm above the horizontal position. Above the horizontal position. This is a key word. That means overhead abduction is involved. And we know that serratus anterior muscle along with trapezius muscle is causing abduction greater than 90 degree of the arm. Also, inferior scapular angle is observed to be prominent. So we know that prominence of inferior angle medial border of scapula is done by, this is the condition called as winging of scapula, and happens by the injury of long thoracic nerve and the paralysis of serratus anterior muscle. That means in this case, as the operation is the operation which has been performed in the lady, and after that this abnormality is seen, is the case of mastectomy, removal of the breast tissues. So this is the right answer. Thyroidectomy generally involves external laryngeal nerve and recurrent laryngeal nerve. Anterior dislocation will involve axillary nerve. Violent stretch of head and the shoulder can cause exactly the brachial plex injury. Clavicular fracture is basically on the site of medial 2/3 and lateral 1/3. So most important correct answer, which will be involved in the serratus anterior muscle forming the medial axillary wall, and approach is happening. We approach for the removal of breast via the space, and that long thoracic nerve is commonly injured. So the right answer is mastectomy. Let's go to the other clinical question. A 45-year-old woman is examined as a candidate for cosmetic breast surgery. The surgeon notes that both of her breasts is sagging considerably. The structure which is more becomes stretched to result in this condition. Which of the following structure is the reason of sagging of the breast? Scarpa fascia, which is the membranous layer of the abdominal wall, pectoralis major, minor, suspensory ligament, serratus end. So basically the most correct answer is suspensory ligament of Cooper. As I already told you, suspensory ligament of Cooper is the fibrous septas which is giving support to the breast tissue. So it sags in the old stage, and that is giving support to the breast. Now the pitting orange appearance, pseudo-orange appearance of the breast is due to which of the following reason? Whether the reason is hematogenous dissemination, adherence of Cooper ligament, chest wall fixation, blockage of subdermal lymphatic. So as already discussed in the clinical aspect, I have told there is blockage of the lymphatic, subdermal lymphatics. That is the reason that there is pitted appearance in the mammary gland or breast gland. So this is all for today. So actually we have discussed all the clinical questions related to the breast gland and mammary gland. We have discussed in detail about lymphatic drainage, the arterial supply, and the important parts and relation. And I hope the session is useful for you. So I will come up with the next topic. All the best and keep studying. Thank you so much.